Thank you again. I am Shin. I'm a postdoctoral researcher at Teachers College, Columbia University. I'm incredibly honored to receive the award and be here and talk about my research. I also have immensely enjoyed listening to the wonderful presentations that came before my talk. So I really want to thank Andy and other members of the Future Directions Launch Award Committee for creating this space. Okay, so in my research, I focus on using mobile technology to study cognitive and emotional symptom level processes in internalizing disorders and suicidality. Today, I would like to share with you a snapshot of my work, especially how I came to pursue this line of research, some examples of my work, and future directions that I envision. My current research has been shaped by my increasing awareness of the research to practice gap and thinking hard about what I can do to help to bridge the gap. Specifically, I have been attending to the disconnect between how we study psychopathology in research and how those clinical concerns are actually conceptualized and intervened on in practice. My focus has been striving to resolve the disconnect by employing novel research methods and conducting more clinically relevant research. In the past few years, this aspiration has shifted my approach to conducting research. My earlier work focused on disorder level research. Disorder level research investigates how different disorders are related, such as how much they co-occur or predict each other over time. I also studied between-person effects or individual differences, such as whether anxious and depressed adults experience more interpersonal problems than healthy controls. Both types of research can provide valuable insights. But over time, I started to feel that solely focusing on these types of research was not fully satisfying. That is because the primary interest in clinical practice is symptom level and within person processes, rather than disorder level and between person processes. For instance, when we say we are treating major depressive disorder, we are not intervening on the abstract disorder entity. What we intervene on are the symptoms that underlie the disorder, such as depressed mood, low energy, and hopelessness. Therefore, understanding symptom level processes, such as how symptoms emerge, reinforce each other, can have direct implications for improving interventions. Clinical practice also fundamentally concerns with within-person processes because our goal is to bring about therapeutic changes within individuals, reducing their symptoms and improving functioning over time. For these reasons, complementing between-person diagnosis level research with within-person symptom level research is crucial to facilitate translation of research findings into clinical practice. This realization has been the main impetus for my current work, where I use smartphone-based ecological momentary assessment, or EMA, to study cognitive and emotional processes linked to internalizing disorders and suicidality. EMA is well suited to symptom level and within-person research because it allows us to assess different symptoms repeatedly across time within individuals. I think of EMA as being similar to a microscope because it allows us to take a much closer look at those micro-level symptom processes that we cannot necessarily observe with just a naked eye or traditional methods like retrospective aggregate self-report measures. For instance, rather than asking participants to summarize their negative emotions in the past week, we can directly assess the intensity and fluctuations of their negative emotions in real time over the course of the week. And that's what my co-authors and I did. So we found that anxious and depressed adults experienced a wider range of negative emotion intensities over time than healthy controls. We also found that in anxious and depressed adults, negative emotions were more sticky, carrying over time and spreading to other negative emotions more strongly. These two dynamic emotional patterns differentiated between the clinical and control groups incrementally beyond the mean negative emotions. This suggests that what we can capture with EMA can have incremental clinical relevance beyond what we traditionally focus on. And if you're interested in learning more about this study, you can access the full article with the QR code. So I just showed you how we can use the EMA microscope to detect micro-level dynamics of an individual symptom, but we can also use it to detect micro-level interactions among multiple symptoms or a symptom network. In this study, I applied network analysis to EMA data on symptoms of generalized anxiety disorder and depressive disorder to examine how symptoms predicted each other over a few hours. In this longitudinal symptom network, each node represents a symptom, and each arrow represents whether and in what direction the symptom predicts other symptoms over time. This is the full symptom network. One of the most interesting things we can do with this network is to find the nucleus or most central symptom of the network. In this case, those symptoms were worry and hopelessness. They predicted changes in most other symptoms across the network over time, but not vice versa. This suggests that intervening on worry and hopelessness can have cascading effects on all other symptoms, deactivating the entire network. Therefore, they can be especially promising targets in treatment. So what I have spoken so far is about the promise of EMA for characterizing clients' concerns, presumably during the treatment planning process. However, what happens after treatment planning? How might EMA facilitate understanding what happens to symptoms over the course of treatment? Here is another place where the EMA microscope can facilitate reducing the research to practice gap, and it has to do with how we traditionally measure treatment response. Most treatment studies tend to focus on discrete time points, such as pre and post-treatment to examine treatment effects. However, we can gain additional useful insights by collecting data throughout the treatment period. Using this approach, my colleagues and I found that in non-directive therapy, chronic generalized anxiety disorder patients fared increasingly worse over time. However, in applied relaxation, we didn't find this pattern. Both chronic patients and those with a more recent onset did equally well. EMA data also allowed us to see that this moderation effect emerged only in the later phase of treatment, becoming more pronounced over time. Again, it's worth noting that we do not have gained these insights just by relying on the naked eye or the traditional pre and post-treatment assessment. So going back to how it all started, what I learned along the way is that ironically, attending to the microscopic details can help to bridge the large gaps between practice and research. This is because the EMA allows us to gain more intimate and clinically relevant understanding of how mental disorders affect individuals. On that note, there are several directions I plan to extend my current work. In my current postdoc training, I'm extending my adult-based work to youth-based research to incorporate more developmental perspectives in my work. I'm also expanding the scope to examine suicidality as well as internalizing disorders. In fact, I'll be presenting a poster on some of my recent work tomorrow, and I'm excited to showcase this work for the first time at the Future Directions Forum. Another direction I'm extending my work is to augment EMA self-report with passive sensor data. As we have seen in traditional assessment batteries, pulling information across different modalities can improve our ability to predict clinical outcomes. I plan to examine how we can capitalize on this in intensive longitudinal assessments. My long-term goal is to use mobile technology to enhance access to mental health care for traditionally underserved populations. Specifically, I plan to investigate feasibility, acceptability, and efficacy of mobile-based clinical tools in underserved populations with high mental health stigma. Before I end, I would like to acknowledge my wonderful mentors and colleagues, as well as all research participants who made my work possible. Thank you.